Well, good morning, everyone. Welcome to the Functional Formulary webinar on understanding blood lipids and their relation to health. I'm really glad to have a little time to spend with you. My name is Mark Pettis. I serve as Medical Director for Functional Formularies, and I also serve as a Director of Medical Education at UMass Medical School, and I oversee the population health initiatives in Western Massachusetts through Berkshire Health Systems. So it's great to be able to drop anchor for an hour or so and to share a little bit about a topic like so many in healthcare continues to just evolve in its understanding and insight. And in review of blood lipids, I can't help but think of a quote. I think it was Mark Twain who said it's not what you don't know that gets you into trouble, it's what you know that ain't so. And there's certainly a lot about the connection between diet, lipids, and cardiovascular risk that I think is sort of challenging conventional wisdom, and I'll share a little bit of that with you today. I just want to mention off the top that this recording will be available on the Functional Formulary website. And in addition, for those that are in need of CPE credit, you can anticipate by email confirmation of that over the next 24 hours or so. So look for that in your email. So let me just get us rolling here. So a few basic objectives for the webinar. Certainly, an area that I want to spend some time on is just re-examining the diet-heart hypothesis that has guided the way that we think about lipids, the way that we think about diet and cardiovascular risk, which, as I alluded to, and as many of you know, as you follow the research, has shifted quite considerably over the last several months. To focus on how this changing perspective on the diet-heart hypothesis is informing our recommendations for those that we are serving in our consultative roles and the various clinical settings that we are in, and what the implications are with respect to reducing cardiovascular risk. And the third objective is to while lipids have been clearly a central focus now for 50 plus years, largely with an emphasis on total cholesterol and LDL, that it's really important in all that we do through our clinical consultative activity to help people appreciate, as I know you do, the broader context within which blood tests or biomarkers are interpreted. So in this model, this more integrative, holistic model, it's very important that we help others think about lipids in the context of the metabolic landscape that they confront, from inflammation to the stress response to insulin resistance, mitochondrial function, et cetera. And it places lipids in a much broader and more meaningful context. So I'm going to be exploring that a little bit with you. And as you know, there are many risk factors for cardiovascular disease. And I've been in practice for 30 years. My background is in internal medicine, nephrology. So many folks that I cared for with renal disease had tremendous burden of cardiovascular disease, and most ultimately succumbed to cardiovascular causes. But we appreciate that while genetics and family history are indeed very important, that our understanding of lipids has really gone far beyond just total cholesterol and LDL, and we'll explore that a little bit. Everyone is aware of the importance of hypertension, smoking, certainly metabolic syndrome and its expression of insulin resistance and hypertension and central obesity, C-reactive protein in the context of inflammation. So this metabolic landscape is one that has many root causes in lifestyle. And we know that most manifestations of cardiovascular disease are indeed related to lifestyle, are very much modifiable through lifestyle, occasionally through pharmacologic intervention. And ultimately, the goal is to help people move well beyond just lowering a total cholesterol or an LDL. I wanted to just briefly remind you of the classification of lipids. And as you're all aware, saturated fats, and I'll spend a little bit of time looking at some of the recent research, meta-analyses, and evidence that is now placing a bit more of a halo on saturated fat. It's this radical notion that saturated fat may not be as bad for us as we once thought. And saturated fats, just as a reminder, on the top free fatty acid of this 3-carbon glycerol molecule that you see below, a saturated fat has no double bonds. And one interesting aspect of being saturated is that it becomes harder to oxidize a fat when it is saturated. And as we look at cardiovascular risk, it's the oxidation of the lipid that seems to be pro-inflammatory, pro-atherogenic. And saturated fats are harder to oxidize because of their structure. If you look at the second free fatty acid on this glycerol chain, that is a mono unsaturated fat. There's one double bond. And examples of that would be oleic acid in olive oil or avocados, very health promoting, very anti-inflammatory. And then the third fat that you see on this 3-carbon glycerol chain is a polyunsaturated fat with double bonds at the 9, 12, and 15 position. And as you know, there are many different types of polyunsaturated fats. Certainly the most widely consumed in our food supply are vegetable oils, these processed seed-based vegetable oils, corn, sunflower, safflower, canola, and they are predominantly omega-6 polyunsaturated fats. The omega-3 family is also a polyunsaturated fat. And as we explore this topic in a little more detail, we can begin to distinguish the qualities of a particular fat that might make it more desirable for the person to consume. And on the other hand, those that are more easily oxidized, more easily pro-inflammatory, and should become targets for restriction or elimination. Clinicians frequently will use risk calculators, and in most of the interventional trials that you see published, there are many different types of cardiovascular risk calculators, and two that I've been in the habit of using through the years include, this is the Framingham Risk Score, and you're all aware of the Framingham study, the Framingham cohort, and this is a risk calculator that really evolved from many years of prospective data collection. And the typical things that you see in these would include gender, total cholesterol, HDL, smoking, diabetes status, systolic blood pressure. And these risk calculators, I think, are most helpful as an educational tool as we work with clients to help them see the synergistic or additive effect that these risk factors have. And generally, once you get above a 10% 10-year risk, you're certainly in the moderate to high risk. And people who find themselves in the 20% or higher risk are clearly in the highest stratum of risk and need much more assertive therapy, often with pharmacologic adjunct to lifestyle. This is another risk calculator that I also really like. It's called the Reynolds Risk Score. And what I like about this is that unlike the Framingham and other calculators that are out there, it adds the highly sensitive C-reactive protein. So it does take into account a biomarker for inflammation with the understanding that cardiovascular disease and perhaps true of all chronic complex diseases, diabetes, depression, cancer, autoimmunity, are largely inflammatory diseases. And so interpreting a total cholesterol or an LDL cholesterol in somebody with a higher burden of inflammation from say, chronic sleep deprivation or chronic unabating stress or a leaky gut or food intolerance will have a different implication of risk than somebody with an isolated elevation of cholesterol, LDL, who otherwise is not confronting other inflammatory risk factors. So I do like the fact that it embeds that biomarker. So just a short historical visit on the diet heart hypothesis, and it really is interesting history. I'm at an age now where I certainly have been around for 60 years, and I'm often I do a lot of teaching in my work with residents and medical students, and it can be hard to appreciate historically many of the sentinel times where the paradigms that became the basis upon which we were taught, upon which we navigate our caregiving roles, upon which we sort of hang our confidence and trust, that in retrospect, many of these sentinel moments didn't always hit the mark in terms of reflecting what was actually going on. And when Eisenhower had his heart attack in 1955, there was a lot of interest in, at the time, what was a growing number of deaths from heart disease, as you can see from this curve. And it was really the work of Ancel Keys, and many of you I know are familiar with Ancel Keys, the late Ancel Keys, who had a PhD in biochemistry, and Keys developed the hypothesis that this growing prevalence of coronary artery disease was largely an increase in consumption of fatty foods. And Keys had a bit of prominence in the pedagogy, the research world, and academic world, and there wasn't any really good clinical data at that time, but it was a hypothesis that just seemed intuitive. If you eat a lot of fat, more of that fat ends up in your blood, and the more fat that ends up in your blood, the more fat is likely to end up in your coronary arteries. And so it was clean, it was simple, it was intuitive, and Keys was an interesting guy in that it was a bit of a blood sport, and academia can be a blood sport. Even to this day, debates around what are the true pathophysiologic and interventional successes are still widely debated, and a lot of people doing really good work can often get chastised and marginalized, and Keys was not too fond of anyone who did not agree with his hypothesis, and it served him well, in that he was basing his theory on what he felt to be true, and but he was quite outspoken about it. Made the cover of Time magazine, and basically said Americans are just gluttons for fat, and recommended at that time that Americans cut their saturated fat from 17% to 4% of total calories, and it was no species of Homo sapien had ever consumed so little fat, but this became the recommendation of the time, and it pretty much dominated the mission of the American Heart Association, and much that came from that subsequently over the last 50 years. There was also a lot of opposition to Ancel Keys, and John Yadkin, who was a pioneer in nutritional biochemistry in the UK, set up the first division of nutritional biochemistry in London, University of London, was very troubled by Keys' assumptions, and much of the research that he had really suggested that there was very little correlation between fat consumption and heart disease, and much of the data was much more consistent with the relationship between sugar and heart disease. And the blood sport that it was, Keys essentially ridiculed Yadkin, said that, you know, he was essentially delusional in his thinking, and history will, in retrospect, suggest that Yadkin was probably on the mark, and a few other sort of noteworthy publications at that time. But the point that I would raise around this sort of narrative, this history, is that most of us would like to believe that standards of care and evidence are sort of pure and without bias, and the scientific method is sort of pure and without bias, and it's awesome methodology. It's the gold standard, but these are human constructs, and often small numbers of very influential people can influence perception in rather dramatic ways, and the very nature of anyone in a position of authority is one where bias can play a significant role, and there has been some recent evidence to suggest that the sugar industry probably had a lot to do with how Keys interpreted much of the data. And Keys did what was called a 7-country study, looking at European countries post-World War II, made the correlation between fat intake and coronary artery disease. And what he failed to include in that sentinel analysis were data from many other countries. There are actually 22 countries he looked at, but he only included 7 in his final publication. And a broader look at this, again, back at the time, challenged this notion. You know, and this was published back in 1957. The association between death rates from heart disease and percentage of fat in the diet available for consumption cannot at present time be accepted as valid. And unfortunately, these contrarian views, as they were perceived, never really made their way into mainstream thinking, education, teaching, and again, the rest, as they say, is history. What made the diet-heart hypothesis so compelling is that, without question, people who consume more saturated fat in their diet will see elevations of LDL. They will see elevations of total cholesterol. So it would make sense that cardiovascular risk would increase as a consequence. But one of the many trends that dietary guidelines led to, as people did cut back on their saturated fat consumption, is that they consume more carbohydrates. And you know, if you're cutting back a major class of macronutrients, you need to get energy from somewhere. And it's very hard to eat too much protein in terms of satiety, and we tend to self-regulate our protein intake. But carbohydrates, and certainly the processed flour-based foods, sugar, subsequently fructose, high fructose corn syrup, were such a part of the evolving modern diet that people substituted these saturated fats, which often took the source of whole unprocessed butter and dairy and meats and eggs, and replaced them with these refined carbohydrates. And I think much of the epidemiology would suggest that that was one of the central shifts in thinking that led to this growing prevalence of obesity, metabolic syndrome, as defined by insulin resistance and hypertension and abdominal fat, and ultimately to what we now confront as an epidemic of obesity, diabetes, metabolic syndrome, etc. If you look at where most of the saturated fat in our blood comes from, it's really not a reflection in general of our dietary consumption of saturated fat. Most of the saturated fat circulating in our serum is from lipogenesis. It's from hepatic synthesis of saturated fats, and de novo lipogenesis is largely triggered by these refined carbohydrates, by sugar, by fructose, and is associated with these clinical syndromes of obesity and hyperglycemia. So Um, there, it's important to appreciate that much of the saturated fat we produce and the triggers of that production really take the form of the carbohydrate macronutrient, particularly the more processed, what I would call carbohydrate dense flour-based foods, sugar, and again, fructose. Fructose coming largely from sugar at that time, and then ultimately from addition of high fructose corn syrup into many packaged and processed foods. So just a quick look at some of the more recent meta-analyses, and there have been several over the last few years. I just wanted to share a few of them with you. These are very rigorous systematic reviews. This was from the Annals of Internal Medicine in 2014, looking at the association of circulating and supplemental fatty acids with coronary arterial disease. And they looked at 37 observational studies, 27 randomized controlled trials. And essentially, the conclusion was current evidence does not support cardiovascular guidelines that encourage high consumption of polyunsaturated fatty acids and low consumption of saturated fats. What a radical departure from historical thinking. Another analysis, this was January of 2016 from Open Heart, also a meta-analysis from randomized controlled trials, not supporting the current dietary fat guidelines. And again, I wanted you just to be aware of these reviews because they're excellent resources to have in your files and to share with maybe some of your colleagues who still look at fat as more the enemy than it may actually be. And again, the conclusions from this meta-analysis are that the evidence simply does not support the current recommendations to restrict dietary fat. And this is a what's called a forest plot. It looks at several trials. These are mostly either observational or randomized controlled trials. And the center line with the number 1 at the basis essentially means if you're to the left of that, there is a risk reduction. If you're to the right of that, there is a risk increase. And if you look at the overall trends, there really is no significant impact in reducing risk or raising risk as you substitute a saturated fat with a polyunsaturated fat. Much of, and this is from the British Medical Journal also in 2016, of the trends from the diet heart hypothesis not only resulted in a greater tendency to consume poor quality carbohydrates of very little, if any, fiber, very little, if any, nutrient density, and certainly the carbohydrate itself, very simple, very high glycemic, very pro-inflammatory, is that many people were told to substitute those saturated fats with polyunsaturated sources. And this really became the basis of tremendous increases in consumption of processed seed oils. And you're well aware of them: corn oil, safflower oil, sunflower oil, canola, soy, and again, there was some evidence to suggest that some of these polyunsaturates might lower cholesterol, and the assumption was made that that would reduce coronary heart disease. But like so many things, some of the unanticipated effects that I think are important for so many folks today is that these polyunsaturated processed seed oils in the quantities that people are consuming have dramatically shifted these omega-6 to omega-3 ratios in a much greater way. And we know that these high quantities of these omega-6 polyunsaturates are much more easily oxidized. They tend to promote inflammation through the eicosanoid pathways. I have a slide that I'll share with you in a moment that looks at that. And in fact, as molecules, they do tend to be more pro-inflammatory even though just looking at an effect on total serum cholesterol might not have predicted that outcome. And again, this is where human biology is in its beauty and in its complexity and in its nuance, doesn't always behave in ways that, in a more linear thinking fashion, one would predict. And this is just a comparison of omega-6 metabolic pathways with omega-3 metabolic pathways. And linoleic acid, the backbone molecule of the omega-6 fats, and again, these are polyunsaturated oils. There are healthy sources of omega-6 like flax oil, chia seeds, nuts, but people get most of their omega-6 from these processed seed-based oils. They will follow metabolic pathways that in high concentrations will be pro-inflammatory. You'll see an upregulation of the series 2 eicosanoid pathways, which are pro-inflammatory, unlike omega-3 sources, alpha-linolenic acid sources, fatty fish being, a good example of that. Certainly, the ALA that one might get in nuts, though converted to EPA and DHA in a much less efficient way, are still much healthier fat sources and tend to be anti-inflammatory. The association of blood lipids as the diet-heart hypothesis has been challenged, has also and is being challenged as we speak. And again, most of the cardiovascular literature has looked at the association between LDL and mortality. And it is again, I do a lot of teaching, and it can be easy when you have sort of checklists. LDL above this high equals statin, LDL below this good equals, pat on the back. There's been a real oversimplification of these connections. And this is an excellent review from the BMJ that looked at LDL. And again, and you have to kind of hold on to your head here because it's so different than what we have assumed. Their conclusions: high LDL cholesterol is inversely associated with mortality in most people over the age of 60. In other words, the higher your LDL, you may actually have a lower risk of a cardiovascular outcome. This finding is inconsistent with the cholesterol hypothesis. Since elderly people with high LDL live as long or longer than people with lower LDL, our analysis provides sufficient evidence to question the cholesterol hypothesis. Moreover, our study provides the rationale for reevaluation of guidelines. This, I'm sure, will continue to be very widely debated, depending on the biases that one brings to the debate. But there have been other studies showing that the lower your cholesterol is, total cholesterol, as you get older, the greater your mortality risk. So this relationship, again, I think is much more complex than what we have thought. And again, just another very recent analysis, and this was a study originally published back in the early 70s, the Minnesota Coronary Experiment. And again, we think randomized controlled trials are the gold standard, and they are. But what you often don't know is data is often excluded in these studies. It never gets reported. There's often bias in selection. There's certainly often bias in interpretation. But researchers more recently have gone back and looked at data, both the original data that was published as well as follow-up data from this cohort. And what they found, and again, I'll just go through this very quickly, the traditional diet-heart hypothesis predicted that replacing saturated fats with vegetable oils rich in linoleic acid will reduce cardiovascular risk. That was the traditional hypothesis. The paradigm was never causally demonstrated. And what they found was that essential data from this original trial were not fully published. And what they found was that a lower cholesterol, when they went back and looked at that data, did not translate to improved survival. In a paradoxical way, those that had greater reductions in cholesterol actually had a higher rather than a lower risk of death. And again, it just added more evidence to suggest that looking back, it becomes harder to make the case for the traditional diet-heart hypothesis and any of the recommendations that have emerged from that. This is the Rotterdam study that many of you may be familiar with. This was published back in 2004. They looked at coronary calcification, and in an effort to explain the French paradox, the French do consume much more saturated fat. And they found that those that did actually had much lower calcific change in their coronary arteries. Calcification is a marker of chronic inflammation. If we have chronic inflammation anywhere in our body, we will tend to form calcification. And coronary calcium scoring, which is a CAT scanning methodology, I'll look at this in a moment, can be a very helpful way of adding more data to determine risk stratification of a particular individual. But from the Rotterdam study, there was a 52% reduction in calcification in people who ate more butter, eggs, liver, cheese, foods that are known to have higher amounts of saturated fat. And one of the implications of a potential benefit of consuming those foods is the fat-soluble vitamin K2, which is menaquinone, K2. And K2, a micronutrient that we don't often think a lot about. And many people are familiar with vitamin K, from green leafies, the phyloquinone. K2 found in animal foods, animal fat, has a very central role in regulating calcium, and in doing so, it puts more of the calcium that we consume and turn over into our bones and prevents calcium from entering our vasculature, our soft tissues, our joints, and clearly people who consume more of these fatty foods, particularly from good sources, are going to get more K2, and that may be an important micronutrient, and I think is a very important micronutrient in cardiovascular risk reduction. And again, there continue to be some outspoken champions. This was an editorial from David Ludwig at the Brigham and Darius Mozaffarian. And again, I think there's still some question as to whether the limitations on fat continues to be inappropriate and unreasonable based on current epidemiology and how the research continues to evolve, and to be focusing much more on our abundant intake of refined starches and added sugar and fructose. Lastly, and again, just a kind of a whirlwind tour of recent meta-analyses has been a more so this is what Yadkin was saying back in 1957. So turn the clock ahead, almost 65 years, and this is from the original investigation from, I believe this was in the Annals of or JAMA, the Journal of the American Medical Association, looking at sugar intake and cardiovascular disease mortality. And again, this looked at the NHANES data, the last three cohorts of the National Health and Nutrition Examination Survey. And again, if you look at this forest plot, without question, there were significant increases in hazard ratios of cardiovascular outcomes, mortality, MI, both fatal, non-fatal, stroke, in people consuming more sugar in the upper quintiles compared to those in the lower quintiles. And much of just to go back to this for a minute, much of this discussion has led to recognition that many of the people like Ancel Keys and others who were central to the diet fat hypothesis, they were heavily supported by the sugar industry. And there is no place in our academic and research enterprises that are truly free from the bias of which isn't a criticism of the people. This is just how we are wired as human beings. And even in our best intentions, our conclusions often are guided less by the truth and more by how we perceive the truth. One last bit of data before I get into just some of the traditional lipid profiling and what I look for and what I find helpful in interpreting risk and in educating and advocating for my clients is data that was published some time ago. And this was some of the original Framingham cohort data. I'm the Associate Dean of Medical Education at the University of Massachusetts Medical School, and many of the cardiologists in the Framingham study were at UMass at that time, and every now and then I get to talk to some of the pioneers involved in this trial, which is still ongoing. And what I wanted, one of the investigators gave me this slide, and it reveals quite a bit. And really what the point that I wanted to make on this slide, because this is old data, this is not recent, is that the single greatest predictor of cardiovascular risk in the standard lipid profile that we get all the time and that we see all the time and that we review all the time is not total cholesterol, it's not LDL cholesterol, it's HDL cholesterol. And what you can see in this graphic is that if you have a high HDL, you have a very low risk of a coronary event, even if you have a high LDL cholesterol. An example of that would be in the first row of sort of light blue colored bars, an LDL of 220, which would give angina to any primary care provider or cardiologist, really did not predict cardiovascular risk when a person's HDL was very high, in this case, 85. In much the same way, you could have a really low LDL, and most of us would look at that and say, well, you're really lucky, you got a good genetic hand of cards, or you're on the right dose of a statin. But if your HDL is low, you do not confer benefit by having a low LDL. So HDL is a much better and proven independent risk factor for coronary artery disease. And this is one of those slides I bring back to my colleagues because we tend to forget how powerful this data was, yet it tended to get forgotten. And as many of you know, there aren't many ways to raise HDL pharmacologically. Big Pharma continues to look for that magic bullet, which will not be forthcoming. If you want to raise HDL, you need to consume more saturated fat. Go figure. The other really important biomarkers from the standard lipid profile, in addition to the HDL, is the triglyceride HDL ratio. This to me is one of the most important things that I will look at. Triglyceride HDL ratios seem to correlate very well with insulin resistance. The more insulin resistant you are, the higher your triglyceride HDL ratio, the lower your insulin resistance, or the greater your insulin sensitivity, the lower your triglyceride HDL ratio. So you can see here that risk of coronary artery disease, once your triglyceride HDL ratio gets up above 2, is really quite significant. And there's a linear effect. And most people with metabolic syndrome, as many as 25 to 30% of American adults, and certainly many kids who are carrying more visceral fat, who often will have very high triglycerides, very low HDL. This to me is a definite red flag for cardiovascular risk, for insulin resistance, and is very much within the purview of lifestyle intervention. This is an example of where lowering the amount of poor quality carbohydrate as a macronutrient, increasing the amount of healthier sourced fat and saturated fat can dramatically, in a very short time, begin to reduce these triglyceride HDL ratios. You bring the triglyceride down, you raise that HDL, and even if your total cholesterol and LDL either remain neutral or go up a little bit, which can happen for some, that does not in any way or should not confound the risk reduction that you were seeing by raising your HDL, lowering your triglycerides, and as a consequence, lowering this ratio. I think this is really important. Many of you may be familiar with the work of Dr. Ronald Krause. He has been very interested in looking beyond just total cholesterol and LDL, and has pioneered a lot of the research and current understanding, which is still very much evolving, to the role of the lipoprotein subfractions. What we would look at as taking LDL and analyzing it in terms of the number of small, dense LDL particles, the number of large, buoyant LDL particles, because within those subfractions, there's a wide spectrum of risk that you will not be able to interpret from just a total LDL. And in this instance, on this graph, Krause has shown that the number of small, dense LDL particles seems to be a strong biomarker prediction of coronary artery disease. And there's a lot of mounting data to support that. He's also shown that the greatest risk of small, dense LDL, and other researchers have shown this as well, people like Stephen Finney, Michael Volek, the greater the carbohydrate macronutrient consumption, particularly of those poor qualities, the much greater. These are strong correlations with pattern B, which is the small, dense, atherogenic LDL particles. And if you look at, these are some composite data from Eric Westman at Duke. In general, if you compare a low-fat diet, and I'm not suggesting low-fat diets are unhealthy, if the quality of those fats are good, if the omega-6, omega-3 ratios are balanced, if the carbohydrates are taking the form of whole carbohydrates from vegetables and fruits and beans and legumes, that's a very different proposition. But most people on low-fat diets are consuming poor quality carbs and poor quality fats. And there's no question that a low-carb, high-fat macronutrient combination will have much greater reductions in triglyceride across the board. These are several randomized controlled trials of the last 15 years compared to a low-fat diet. And again, this is the HDL. You see dramatic increases in HDL, again, when you adjust macronutrients in this way compared to a low-fat profile. And again, the more one consumes these carbohydrates, the greater the tendency to have the small, dense LDL, as you see to the right. As one reduces those poor quality carbs, it begins to reintroduce higher quality fat, saturated, monounsaturated, polyunsaturated, coming from good sources of omega-6 and omega-3 in particular. You see a significant migration toward the large, buoyant LDL, which is not atherogenic, it's protective, and you will not get that analysis from a simple lipid profile. So these are some of the biomarkers that I think are important in addition to what we just discussed. These next couple of slides are from the Cleveland Heart Lab. They do great work. I have no vested interest in the Cleveland Heart Lab, but again, small, dense LDL analysis I think is increasingly important. Does everyone need it? No. But if someone is at risk, if they have, say, a 10% risk based on one of those risk calculators, if there's some consideration of a statin, if there is an opportunity to better manage through lifestyle, then I would definitely consider getting a particle analysis, and that can be very helpful in adding to your ability to risk stratify, to monitor, and to help people connect lifestyle with their lipid biomarkers in a very, very powerful way. Lipoprotein A, this is one of the more genetically determined cardiovascular risks. I don't measure it routinely, but I think it's important to know that it's out there. A high lipoprotein A can be, it's virtually impossible to change this with lifestyle. And these individuals, particularly with a high family history, may in fact require pharmacologic intervention in addition to lifestyle. C-reactive protein, a very important biomarker for inflammation. I anticipate probably over time we'll see many more biomarkers of inflammation emerging, but it's the most widely available and helpful. As you may know, C-reactive protein can go up and down depending on whether you might have an allergy at the time or a respiratory infection at the time. So I find C-reactive protein most helpful as in terms of patterns, having multiple points on the curve. And somebody at moderate to high risk, I may check it twice a year. And I'm really looking for patterns, and it can correlate nicely with either increasing or lowering inflammatory burden. The F2 isoprostanes and the oxidized LDL, again, these are not biomarkers that I get routinely, but they have emerged as additional biomarkers. The isoprostanes are another inflammatory biomarker, and there may be some requirement of additional documentation to get it covered, by a payer. But I do think it is a very valid biomarker for inflammation, particularly as it relates to inflammation from oxidation of fats, arachidonic acid. And oxidized LDL in much the same way can be very helpful. A person may have a high LDL that's not oxidized because they have a very low inflammatory burden. It's the small, dense LDL particles that more readily lend themselves to oxidative stress. So again, these can be additional biomarkers of some help. I don't routinely get them as first line, except for the highly sensitive C-reactive protein. And again, a few of the biomarkers that you'll hear about and that you may use and interpret is microalbumin. This is a urinary microalbumin, very helpful as a nephrologist. I've been doing this for years. It's a very helpful biomarker of endothelial damage. And if you have small amounts of microalbumin in the urine, that's probably a very valid biomarker for endothelial damage throughout the body. You just happen to be picking it up through urinary excretion. Myeloperoxidase, also an inflammatory enzyme, very high in people that have active atherosclerosis and oxidized LDL. And then lastly, the ApoB, ApoA1 ratio. My simplified way of thinking about this is that the ApoB is really a marker for the LDL, and small dense LDL tends to have ApoB that is less functional, in that our livers can't remove small dense LDL based on the ApoB receptor as well. So these small dense LDL particles circulate much longer, take longer to clear, have much more time to get oxidized, and to create atherosclerotic risk. A1 is the HDL, and certainly you want more of that. So in looking at the ratio of ApoB to ApoA1, generally I want to see that ratio to 0.7 or lower. And in much the same way that one can lower their triglyceride HDL ratio, one can very significantly lower their ApoB, ApoA1 ratio through modification of macronutrients, as we've talked about, restricting the poor quality carbs, reintroducing and having more abundant intake of healthier saturated, monounsaturated, and in particular the omega-3 polyunsaturated fats. I will occasionally look at two additional tests. One is a coronary calcium score, which I alluded to earlier. This is a CAT scan protocol, so there there is some implication for low dose radiation, as one would get from a CAT scan. But you're actually looking at the deposition of coronary calcium, as you can see in that top figure. And through algorithms and CT analysis, you can quantify that. Generally, a calcium score of greater than 200 would be considered significant. Lower is better. And again, I find this very helpful in someone who may need more aggressive pharmacologic intervention, or even interventional cardiac intervention, stenting, whatever that need might be. People coming in frequently with chest pain, you're not sure if it's ischemic or not. Having a high calcium score would lower your threshold to work these people up in a more invasive way. I know many of you are also familiar with the ultrasound test, the carotid intimal media thickness. This is a really nice biomarker, very non-invasive, no radiation involved. You're basically putting a probe over the carotid. And as you can see in this ultrasound image, you're really looking at the thickness of that inner endothelial medial layer. And again, they're very good criteria for interpreting that and using that as a risk factor. This is a typical small, dense LDL, a more involved lipid profile. This is Quest. I just use this as an example. This is called cardio IQ. Sometimes a lab might refer to these as NMR lipid profiling, ion mobility profiling. More labs are doing this. And again, here you're looking to just add information to allow you and the individual you're working with to better stratify risk. I think there can clearly be a role for this as part of that testing. And again, really, we want to try to help people who have a high LDL or a high number of LDL particles to shift them into a more pattern A, a more optimal risk. And much of the current data would suggest that, again, sound like a broken record, but this is really more of a carbohydrate issue and a willingness to introduce healthier fat sources as a way of restoring and modifying that risk. And one can do this very significantly with lifestyle. A statin will not achieve that. So how do we interpret all of this as we bring this home? And again, I'm sure you could see this coming. Sugars and starches are definitely problematic, and we know that we simply consume far too many of these food sources. But it can be very non-intuitive to consider that a food that has no fat can worsen your fat profiling, and it can take a little while to sort of address that cognitive dissonance. And so I try to help people deconstruct their paradigms of understanding, and literally to reteach them that many of the things that might be labeled low fat or no fat are being substituted with macronutrient, nutritionally void foods that are wreaking havoc with not just their lipids, but their immune systems and their gut, et cetera. And becoming more comfortable as we, again, sort of deconstruct paradigms that have guided us away from many healthy fat sources like pasture-raised eggs and fatty fish and ghee. Is an awesome, grass-fed butter, and ghee is clarified butter. Very, very helpful. Whole fat dairy, if casein isn't an issue for folks, whole fat dairy I think is clearly more beneficial. Extra virgin olive oil and avocados as excellent sources of monounsaturated fat. Coconut oil, again, is saturated fat, but a healthy source, lauric acid. These are shorter and medium chain fats. And of course, nuts, almonds, macadamia. Macadamia is one of my favorites because it has a fat profile a lot like olive oil. It's predominantly monounsaturated, saturated, and can be a really good food source for snacking, and much better than what most people might otherwise choose. Quickly, I just want to touch on statins. it's a bit of a loaded topic. My lipids have been high in the past. I totally reversed my risk with lifestyle. I could have easily taken a statin. I have samples. I can just reach into my closet and grab them. Statin's greatest risk reduction is in secondary prevention. Nobody would question that. If you've had a prior heart attack or a stroke, statins will very significantly and measurably improve your risk. However, I would suggest that more of that risk reduction comes from lowering inflammation, perhaps, than LDL lowering, even though LDL has been the focal point of emphasis. Statins, I think, have very much underreported side effects in the published literature. They have no effects on triglycerides or HDL, and except to maybe reduce HDL. And I just before I conclude, wanted to make you aware of what I think is a really good website. I use this website a lot, particularly when I'm working with clients and patients. It's called the NNT, the NNT.com, the number needed to treat. It's hard for many people to sort of interpret clinical trials, and we talk about risk reduction, relative risk reduction, absolute risk reduction. It's very hard to interpret that in a way that can give a person or even a caregiver a tangible way to sort of quantify the effect. This website does the reviews, does the analysis, and develops a number needed to treat. And if you look at statins, and here this is giving statins to people who don't have known heart disease. The number needed to treat to save a life, none were helped with a statin. There's really no evidence to suggest that in primary prevention, you're going to reduce your mortality with a statin. For every 104 people who took a statin, 1 heart attack was prevented. For every 150 people who took a statin, 1 stroke was prevented. That's the number needed to treat. It puts things in I think, a more manageable context. 1 in 50 were harmed in terms of diabetes. 1 in 10 were at risk of muscle damage. So the number needed to harm is relatively small. So this becomes a harder proposition unless you have multiple risk factors and have a 10-year risk that's at least 10, and I would say more significantly 15 to 20% risk over 10 years. But if you look again at people that have known heart disease, secondary prevention, the number needed to treat for 83 people on a statin who've already had a heart attack for 5 years, you will save 1 life. For every 40 or so, you'll prevent a second heart attack. Those are very meaningful risk reductions when you look at the large-scale epidemiology and risk benefits. So I find this can be helpful in helping others sort of quantify risk and reflect a bit more on the power of lifestyle. And I think I'm preaching to the choir there. So in summary, I think the lipid profile is sufficient for most as an initial screen. I think if somebody is at higher risk and you want to get more detail to help guide them, I would certainly consider a lipid subfraction, whatever lab you like to use, the ion mobility, the cardio IQ testing. These are available in all labs now, and with appropriate documentation. Rarely are they not covered. Often I will repeat testing in about 3 months. Occasionally introducing more fat can be problematic for a small number of people who may have an ApoE4 genotype. Time didn't allow me to talk too much about that, but over 90–95% will benefit greatly. But I do think it helps to have before and after, so you can just monitor that. C-reactive protein, the A1C is a sugar glycation, the HOMA-IR, this insulin. These can be very, very helpful. Trying to get that triglyceride HDL ratio less than 2, reducing sugar and flours and more abundant healthy fats, cutting back on these seed-based omega-6 vegetable oils, very important. Getting more K2 butyrate in animal fat, particularly dairy fat sources. Fiber rocks at many levels when you look at the gut and inflammation and the ways in which one can modify their metabolic landscape. through plant-based foods, in addition to the nutrient density that those foods do to improve inflammation and insulin sensitivity. And so these become part of that broader context of moving more and sleeping better and managing stress. And that was a bit of a whirlwind, and I hope very helpful to you. And again, I want to remind you that this will be available on the Functional Formulary website. And for those expecting CPE credit, look for that by email over the next day or so. And on behalf of the team at Functional Formularies, I'm very grateful for your service, your stewardship, and hope this was able to help you along the journey. Thank you very much for listening. Take care. Have a great day.